it is. Okay. So, nephrotic syndrome is a kidney disease affecting tens of thousands of children worldwide. My research at SickKids Parekh Lab at SickKids Hospital is focused on determining how often and why children are hospitalized with nephrotic syndrome for adverse complications. So nephrotic syndrome is an idiopathic, relapsing, and remitting kidney disease. That means that we don't know what its cause is, it's not preventable, and it is recurring. So normally in the kidneys, the glomerulus is the unit that filters the blood. However, in nephrotic syndrome, the cells, as you can see here, on the glomerulus are damaged, causing protein to leak into the urine. So a lot of protein is lost in this condition. Since my project is focusing on hospitalizations and nephrotic syndrome, it's important to note that hospitalizations can result from infectious or non-infectious complications, and that protein loss in nephrotic syndrome leads to increased susceptibility for infections. It's also important to note that steroid-resistant nephrotic syndrome patients have a more complicated disease course, which may increase their risk of experiencing hospitalizations. Currently, there's a lack of research on hospitalizations in children with nephrotic syndrome. But one of the studies that has been done shows that of 50% of children that were hospitalized with nephrotic syndrome, they developed a condition that is non-infectious called acute kidney injury, or AKI. And of these children, 13% also had an infection. There have been other studies that have shown between 19 to 37% of infections in hospitalizations for these children. However, the problem is that the studies that have been currently done are retrospective, meaning that they did not look at the complications and hospitalizations over time, and therefore we don't know the risk factors that affect hospitalizations and complications over a prolonged period of time. So in order to fill in this gap, we determined the incidence of hospitalizations among children with nephrotic syndrome. We determined the cause of the incidence of each hospitalization, and we looked at whether steroid resistance increases risk or affects the risk of hospitalizations. So to determine the incidence, we abstracted data from what's called the Insight into Nephrotic Syndrome study. And this is a disease-based longitudinal observational cohort study which focuses on nephrotic syndrome. We abstracted data from 1996 to 2016 for 331 children with idiopathic nephrotic syndrome between ages 1 to 18 years old, who were hospitalized at SickKids Hospital after their initial diagnosis. Upon determining the incidence, we assessed whether steroid resistance, our primary exposure variable, affected the increased risk of hospitalizations. And our main outcomes were the incidence of first hospitalizations using time to event analysis, the cause of these hospitalizations, and the Cox proportional hazards regression model in order to assess the effect of any covariates. So as you can see here, these are our inclusion and exclusion criteria, which as listed are the inclusion and exclusion criteria for the overarching Insight study. But specifically when we abstracted the data, we included hospitalizations that occurred after the initial diagnosis, and we also excluded any hospitalizations for a rituximab infusion, an organ transplant, and a renal biopsy. And our main exposure variable was steroid resistance, which we compared to steroid sensitive. And steroid sensitive patients achieve remission within the first 4 months of corticosteroid therapy, while steroid resistant patients do not, despite being on a daily prednisone dose, which is the normal corticosteroid that is given to them. So for this project, admissions after diagnosis for nephrotic syndrome were either infectious or non-infectious, and this was categorized as a hospitalization. Infections could be viral, bacterial, or fungal, and non-infections included basically everything other than that. So that could be acute kidney injury, pulmonary edema, relapse, or thromboembolism, etc. So after abstracting all of the data, we summarized it in a baseline information in statistics of all hospitalizations. We conducted survival analysis and a Cox proportional hazards regression model to analyze any effects of different covariates. So this table shows the baseline information, and as you can see, the median age of diagnosis was 3.7 years, and the majority of our cohort was male. Our cohort was multi-ethnic, and the majority of the parents of these children were well-educated. Additionally, most of these patients in our cohort were responsive to steroids. So of the 331 children in our cohort with nephrotic syndrome, 122 were hospitalized, with 335 hospitalizations, and a median of 2 days per hospitalization. Most hospitalizations occurred due to non-infectious complications, followed by both infectious and non-infectious, and then infectious only. And the median length of stay was 3 days. So this graph shows a survival analysis of the incidence of hospitalizations in children with nephrotic syndrome. And basically what you can take from this graph is that if you follow 1,000 childhood nephrotic syndrome patients for 1 year, you will see 95 new cases of hospitalizations. And so now that we determined the incidence of overarching hospitalizations, of all of them, we looked into the specific risk factors that affected hospitalizations. And through univariate analysis, we saw that steroid resistance had a significant effect on hospitalizations. So we compared steroid resistance here to steroid-sensitive patients. And what we saw was that within the first year of hospitalizations, both steroid-sensitive and steroid-resistant patients had the most hospitalizations. However, steroid-resistant patients had much more hospitalizations within the first year. It's also important to note that since there are only 17 patients that have been abstracted for steroid resistance, we can only look at the first and second year since initial diagnosis. So next we conducted a multivariate Cox regression analysis, and we determined that steroid-resistant patients were at about 2.5 times more likely of being hospitalized than steroid-sensitive patients. And all this was adjusted for age of diagnosis, sex, steroid response, and the child's ethnicity. So what's great about this study is that we had a longitudinal cohort with a very large cohort size and a long follow-up period. Unlike the previous studies that have been done, we are able to look at the effect of these complications and occurrence of these complications over a prolonged period of time. Our limitations include that we only considered hospitalizations occurring at SickKids Hospital. We did not adjudicate abstracted data by 2 reviewers. We lacked data on lab work just prior to admission, and we did not include emergency visits. So overall, 1/3 of all children are hospitalized after diagnosis with nephrotic syndrome, and we determined this through using a survival analysis. We also determined that infection is actually not the most common cause of hospitalizations, unlike previously described. And we determined that children who are steroid resistant are about 2.5 times more likely of being hospitalized than steroid sensitive patients. So what are the next steps? The next steps include determining the specific causes of each hospitalization, the specific types of infections, non-infections, so that we will be able to know how to better predict which infections occur and better prevent them from occurring in the future. So I'd like to thank Dr. Romi Parekh, our principal investigator, Dr. Albo Chanchlani, Yovanka, Tani, Dr. Anna Catalina, and all the students at the Parekh Lab, in addition to the IMS program for funding this project over the summer. Thank you so much.